have, if it works out well, we'll have instructions for you. But you go to Accessibility, it only works on Android devices. I have hearing aids, but I have an Apple, so I'm out of luck. And so you go to Accessibility, hearing devices, hearing aids, settings, find an audio stream, and it's listed under AudioCast 4. If it works well tonight, we'll have the paper and you can get set up beforehand. So, good evening and welcome to the Jaffrey Civic Center. This is Stories to Share. My name is Sean Driscoll. I'm on the board here at the Civic Center, and I'll act as moderator for the talk tonight. Stories to Share is a series of talks that we have on the first Friday of the month in the winter here at the Civic Center. And we skipped January, but we're back in February because the weather is so nice. And we'll keep doing it until May. We're able to do this because of the support that people give to the Civic Center, and because of 3 sponsors for these talks, for Stories to Share in particular. And those sponsors are Beltates, the Savings Bank of Walpole, and the Monadnock Ledger Transcript. So we're very thankful to them. The way this works is that Dr. Vache will speak, and he has the hour till 6. If he finishes early, we can take a couple questions. In any event, we'll end at 6 p.m. And then following the talk, there is a reception in the conference room graciously provided by Nancy Beltate and John Duval. And so we encourage you to stay around afterwards and talk to other people and maybe ask the doctor some questions. So by way of introduction, many people here know that I'm a public school teacher, and so I understand this dynamic that if I ask someone about public school in writ large, it's always incredibly negative. They'll say, "Oh, test scores are down, and it's underfunded, or we overpay, or the teachers are overworked, or the teachers aren't good." And so you hear a litmus of negative things. But if you ask people, what about your schools in your town? They say, "Oh no, our schools are great. We love our teachers, and we have great sports, and we and our robotics team just won the state," or something like that. So there's this strange dichotomy. And as soon as we put Dr. Vache on the program here, I started to think maybe the same thing is true about healthcare, because when it comes to healthcare, it just seems like there's so much negative. And yet, as soon as we had his name, all I heard were wonderful things about him. And people they were excited, and they said, "Oh, he's so great." So originally from Armenia, he has worked in at least 3 countries, in Germany, Russia, and Qatar. And then he came to the United States, and he's worked in cities like Baltimore and Providence, Rhode Island. But on the sort of totally uplifting end of things, in an article in the King Sentinel, he said the technology at Monadnock is at the same level as the technology at those bigger institutions. And so since he came to Peterborough, he has done over 200 minimally invasive spine surgeries. And our own from Jaffrey, Betty Shea, is on the MCH website saying that his team was dependable, efficient, and most thorough. So I feel like we are really, really lucky to have Dr. Vache in our community, but we're especially lucky to have him with us here tonight. So please give a big Civic Center welcome.
Thanks, Sean. Thanks, Sean. Thanks for introduction. Thanks for being here. It's a really great pleasure and privilege.
It has to be louder.
Yeah, thank you. Is it better now? Yes. It's a privilege and honor to be here. Thanks for the invitation. It's really great to see this big turnover. By the way, I share your sentiment about public education. I'm a product of the public school. My entire life, my entire education was based on a public system, and I believe the public education and great public schools are the backbone of prosperity for every country. So, yeah, big shout out, for big kudos to all public school teachers. Yes, so it's been great. I'm here at Monadnock Hospital. Now it's my 4th year. It's been a great journey, and great staff, great hospital, and all of this won't be possible without support of the hospital and my staff. And yeah, my MA is here. Linda, thanks for coming. So today's talk about this current trends, current state-of-the-art practices in orthopedics. So medicine is developing, so technologies are advancing, our understanding of physics, of technologies, of human physiology is changing, and everything is progressing. So everything is progressing, and our understanding as well progresses. So now lots of buzzwords. If you talk about current concepts of medicine, there are lots of buzzwords. Like we talk a lot about the quality of life. We talk a lot about minimally invasive surgery. Then I bet you heard about robots, about 3D navigation, about artificial intelligence. So where are we now? Where are the current state of medicine in general? Because I'm not going to talk about medicine, I'm going to talk about orthopedics and the subjects which are more close to my heart, which are my area of expertise. This will be spine surgery, joint replacement, and we'll talk a little bit about deformity correction, how all these new technologies are changing our current understanding or our current practices of these surgeries. So I'll start a little bit with statistics and trends. So as you can see here, the general number of patients undergoing spine surgery specifically here, it's increased dramatically. And when you compare with hip and knee surgeries, hip and knee replacement surgeries, which increased only by 15%, spine surgeries increased almost doubled, more than doubled. Needless to say that the spine problems overall results in lots of healthcare burden. So 6 to 7 million people in the United States alone are disabled due to some spine condition, and anyone experiences spine problems over the course of his life, so almost 100% of population. So this is just a glimpse about the spine market, about spine surgery market, how it develops and how much money it involves. So, I mean, it's huge. If you think in the United States only, like currently in 2025, spine surgery market is approximately like 11 billion. And is projected to grow up to 16 billion in 2023. It's a huge amount if you think about that, and it's only spine surgery. So what is that? So I think the answer is here in this photo. So this is the generation of 80s. Maybe my grandfather, my grandma sitting quietly on the porch. That they just don't do anything. They just relax, enjoy their retirement. This is your generation. This is the current generation. So people in their 60s, their 70s, they are much more active. They are much more healthier. So and they want to be active. You want to enjoy your life, travel, and be as active as you were in your 40s, 50s, which is totally acceptable, totally understandable, and doable. However, this results in certain spine issues, certain joint issues, and we see what? We see increase. Here, we can see that the spine surgeries for the people aged 60 and over has increased 230% over the last decade. It's a huge number, and we priorly we haven't seen this type of increase. So it's quite significant. Now, there is another a complex issue which arises here. So if people want to be active, right, and if they're in 60s, 70s, obviously they might have some cardiac issue, some heart problem, a chest problem, some other joint problem. And from that perspective, doing minimally invasive procedure, replacing major traumatic procedures with minimally invasive procedure carries lots of value. Why? Because we cannot expose patients with some other comorbidities to major surgeries. They won't tolerate it very well, but they will tolerate minimally invasive procedures. So that's why we have like significant growth on minimally invasive techniques as well. And here you can see how the proportion of age group changed over the course of years. So you can see here in 2003, most of the people, they were below 64. But here now, it's almost half-half. So these are current trends in minimally invasive surgery. So this Monadnock Community Hospital, so I believe, this is my strong belief, I hope lots of people, and I'm grateful lots of people in Monadnock Hospital and in administration share my vision that we are in the great place to advance minimally invasive techniques and outpatient surgery. Because that's what most of the population, most of our community needs. So there are some other techniques, like again, these are again buzzwords we use in the spine surgery. We use it's not only buzzwords, actually these are scientific concepts which we are implementing every day. So it includes enhanced recovery, it looks motion preservation technique, robotics and navigation. We're going to talk about a little bit later. Those are the names of procedures, so I'm not going to stop here. It might appear to be a little bit too technical, but I want to pay your attention on here. So most patients are getting discharged on the same day or next day after surgery. So we are not experiencing major complications. I don't put these numbers here, but our complication rate is 3 times less than national average. It's like we are, I didn't have the recent data, but data from 6 months ago, we were 5.5 when compared to 17 nationwide. Why is that? First and foremost, because we are not doing major complicated surgeries. Second, and I'm not gonna be modest here, we are good, or our entire team is doing a great job of taking good care of our patients, but to be absolutely honest also, I have to mention that we are doing procedures which are less invasive and hence having less number of complications. So if we talk about the cervical spine surgery, this was the gold standard. We use this type, we were doing this type of surgery, this cervical fusion surgery for around like 40 years, like 40, 50 years. It's a pretty straightforward fusion procedure when we fuse 2 vertebrae together and attach it with plate and screws. However, and these are the procedures performed here at Monadnock Hospital. These are some of our patients presented here. But with advanced technology, we realized that motion preserving procedure is much better than fusion procedure. So, I mean, a human body is designed to move. Spine is designed to move. Vertebrae are designed to have some movements there, and this allows a smooth load distribution around the spine. If we fuse one segment, other segments are getting loads. And the question was to achieve the same result and preserve the movements at the segment. So initially, like if you look at the literatures like 20, 30 years ago, we don't have great results, but with new advances of technology, with new materials, with new implants, we are able to achieve motion preserving surgery, do the same procedure and do disc replacement. So this allows to lower reoperation rate, lower the pain, and it has great results. If you look here at this implant, it has ceramic core. It has special polyethylene, special polymer here, and it has here titanium coating, which allows bone ingrowth into this titanium, which is a great advance. So these are just the most recent publications I got. So this is from 2025. which shows that motion-preserving surgery, cervical disc replacement, have a favorable safety profile and lower reoperation rate when compared with gold standard. And many publications with different sources. So AO Spine is a very, very high-ranked journal. It's with North America and Europe combined study, which shows that those patients are, those results are very comparable. And here, there's another study, again, it's very recent, 2023, which showed that disc replacements they have much more beneficial effect. So these are the number of disc replacement patients. If you see from 2009, it has been 121, and here 2022 we have more than 2,200 surgeries performed. These are the CMS data. This is for entire United States, so a dramatic rise. So what is the gold standard now? Gold standard has changed. Now we are performing this procedure, cervical disc replacement, as a first choice if indications allows. And this significantly changed, if you allow to say, revolutionized the treatment of some pathologies of the cervical spine. This is another implant. Those are all patients performed here at Monadnock Hospital. I'm just showing different implant, different system, and we are one of the, I think Monadnock is the only hospital north to Boston who performs this specific type of implant, who uses this specific type of implant for cervical disc replacement. So the other aspect of surgery, spine surgery, which I want to talk, is a minimally invasive surgery. So what do you mean with minimally invasive surgery? This is a traditional surgery. When patients have large incision, like 6, 7, 8 incision, and all this muscle dissection to get down to the spine. And this is the minimally invasive procedure, when incision is usually less than 1 inch, and everything is done through this tube. This is my OR. This is a photo from my OR. Usually I'm not showing OR pictures in general audience. It might be too graphic, too much blood, too much exposed body parts. But this one, look, what do you see? This is the patient's spine. Patient's lying on his stomach, and this is a tube. The diameter of the tube is less than 1 inch, and the entire surgery is done through this inch, through this hole. It's pretty much standard of care now at Monadnock. So almost, rarely I do open surgeries. Even like multi-level diseases, so we progress with minimal invasive procedures. So what's the advantage? Very quick recovery, very few complication rates, happy patients, happy anesthesiologist, happy employer, happy family member. Why happy employer? Because they return to their work much faster. So yeah, I like this slide, and people like this slide, so that's why I put it here. So let's say if someone has a disc bulge or low back pain, and they come to my office and tell me, hey doc, I don't do any heavy work, I'm not working in construction, I always sit in my office and do my computer job. And I bring up this slide always, and I say, hey, look at this. This is the pressure on your disc on different position. So when we lay supine, pressure is very low. Now pay attention to this. When someone stands up, and when someone sits and bends forward, or sits and bends forward here. So the pressure when you sit and bend forward is almost twice more than when you stand upright. So, and that's the reason for continuous low back pain or disc bulge. So people who sit, especially sit in bed posture, they expose their lower spine to much more pressure when they stayed upright. So biomechanically proven. And this is what's predisposing for disc bulges or this type of condition or chronic low back pain. So what is the advice there? Progress with physical therapy, stretching, strengthening exercises, pay attention to the posture. So this is the comparison between different techniques of performing surgery. This is an open spine surgery with incision. This is the tube, which I showed you before. And this is even better, even more minimally invasive. We call this ultra minimally invasive procedure, or otherwise endoscopy of the spine. So here is incision is teeny tiny, is a smaller, it's the size of the pen. It's like few millimeters only. Oftentimes it requires one stitch, not more than that. And again, the entire procedure is done through this ultra minimally invasive technique. Here are how it looks in the operating room. This is one of my OR photos. Again, patient, spine, tube, very teeny tiny. This is how it looks under the X-ray. We are using X-ray augmentation here as well. So we do X-ray to visualize our entry point. Then we put an endoscopy. It's a small tool with camera which goes to the area of interest where the disease is, and the entire procedure is done through this. As a result, patients are routinely getting discharged on same day, routinely returning to their daily activities almost immediately. So we have 16 times decreased infection risk. Why is that? Because incision is small, because we are not opening up, we are not dissecting the muscles, we are not damaging the tissues. Of course, decreased pain, no significant opioid use, and you probably have heard several times that patients who are overweight or obese, they are under increased risk of complications because of the body habitus, because how the soft tissues are getting injured during the approach. So endoscopy, this is very important sentence. I mean, you won't see this a lot in medicine. So this procedure negates the effect of obesity. So, I mean, literally, if I have to do large fusion procedure with big surgery, big incision, I would advise against it for patients who are let's say BMI is over 40, but for endoscopy, I don't have same concerns because I know that my incision is very teeny tiny and damage is very small and the infection risk is very low. So this negates the effects of obesity, which is again very important considering the rates of morbid obesity. So again, these are certain data. This is again scientific data proven from different publications. So if with regular procedure patients stay in the hospital for 4 days, here they stay less than 1 day, and it decreased the surgical time, decreased the opiate consumption. I looked up some statistics. In fact, I got these statistics. I was attending a symposium in Seattle last year. So only 3% of spine surgeons do endoscopy on a regular basis. So if you take the statistics, in the US are 5,000 spine surgeons. So it means that in entire country, 150 to 200 hospitals do the endoscopic spine surgery. And guess what? At Monadnock Community Hospital is one of the few in New England who offer this. So this including huge Boston area. Imagine all these major hospitals. So I mean, I'm very proud of this, and again, our entire team did great work on pushing this forward, and we continue pushing this forward. And again, here at the hospital. So this is another minimally invasive procedure which I want to talk about. This is closely related to osteoporosis. You know that people with osteoporosis, they sustain vertebral fractures very easily. It can be just simple bending or sneezing or coughing or small road bump. And again, with this minimally invasive technique, we can put bone cement into the bone, into the broken vertebra. And again, it's a day procedure. Like patients spend a couple of hours in the hospital, go back totally pain-free. And we are in the process of bringing another minimally invasive procedure. It's not here in my slide. I just want to give you a heads up. It's a totally new procedure from Boston Scientific, and hopefully we'll be implementing next time, and I'll present that one as well. These are minimally invasive fusion procedures, so it's a little bit more complicated, a little bit more minimally invasive, but still minimally invasive. And again, we are successfully established this program, and patients are getting discharged with much a quicker return to their daily activities. So I want to switch gears here and talk about a little bit about joint replacement. Total knee, total hip replacement. Who has total knee, total hip? Many, right? Hey, great. So everyone has, or everyone knows someone who has knee or hip replaced. So do you know the numbers? How many total knees are performed per year? Look at these numbers. Huge. And this is in the US only. So more than 700,000 total knees and more than 500,000 total hips. And numbers are projected to grow. And this number is growing. It's growing every year. We're going to have more and more total hips and total knees. So, I mean, yes, we have lots of achievements, lots of new technologies, which allows our implants to be to serve a longer time. We increase the longevity of the implants. But there is something else which I want to talk about. So, yeah, this is the number. This is the number of the surgeries. See this graph. This is from Journal of Joint and Bone Surgery. Statistical analysis. I think it's from Johns Hopkins. Again, I got this publication. It's a very recent publication. This is projected growth of total knee, total hip surgeries. So see, so total hips, 2016 projected to be 2 million per year, and total knees even much more. So it's increasing. So we are using robots. So this is something I just really want to introduce and to talk a little bit about. So we don't have, just full disclosure, we don't have a robot right now at Monadnock. I hope it's only temporary, but it's something which is getting introduced and getting used more and more broadly. Imagine a robot that's doing surgery. Not entire surgery, part of the surgery, not without surgeon's interference. Yes, still you have to have a surgeon there. And currently, there is no evidence that robotic surgery is doing any better than non-robotic surgery. Again, full disclosure. But see, I just kind of want to stress this word currently because I'm a strong believer that it's going to change. It's going to change. This is my personal subjective take on this. So again, another publication from Journal of American Academy of Orthopedic Surgery, and all these are very reputable journals, evidence-based articles, and again, this was quite recent. This was again quite recent. So a robotic knee replacement is projected to reach half of all knee replacement surgeries by 2030. So four more years, and is projected to be there in 50% of cases. So what it does, so it increases the accuracy, it increases the time, it decreases the time, and it increases the efficacy. And we have certain evidence. So how it works? You may ask how the robot works. So this is the core. This is the basic, very basic technological backbone. So it has a workstation, which is a brain. It has cameras here, like kind of eyes of the robot, and it has a robotic arm. It's being used for the spine surgery as well. So robots are helping us to do knee replacements, helping us to do hip replacements, shoulder replacements, and spine as well. So here I bring some data from spine surgery. So in one of the large institutions, when they implemented the robot, in 1 year they saw almost $500,000 of saving, like conservative estimate of saving. So where the saving comes from? From the time. Obviously, robot and exploitation cost some money, but if you decrease your OR time, if you decrease your complications rate, you are saving some cost. this is another a publication from Journal of Spine. So it says that it's a safe and a very accurate tool to use in spine surgery, and most importantly, decreases the radiation for the staff and for the patient. So, I mean, patients are getting lots of radiation, not lots of radiation, of course, but it is radiation during the surgery, and surgical team is also getting some radiation. So, however, it's there to develop. So, these are the FDA-approved robots by year. So, you can see this is 2017, and I want to reassure you there now at 2026, there are like double of these numbers which got FDA approved and which are getting used more and more. Look at this data. So these are publications involving robots. So you can see how they're spiking in 2024. What does it mean? Again, I'm not bringing technical details, just a general idea how many publications we have recently about the robotics in surgery. And number of publication is talking about that this is so much there. This is so much in development stage, and there is so much to take it from there. So how about augmented reality? So probably you have seen in sci-fi movies, people are playing with augmented reality, manipulating things with their virtual glasses, putting moving blocks right and left. Do you think it's science fiction? Yes, no? It's not a fiction. I would just delete the word fiction. It's science now. And this is real, and this is how we use the augmented reality in spine surgery when with special AR glasses, surgeons are able to see the anatomy and the projected reality in front of them while doing surgery on the sterile field. So a couple of weeks ago, I was in New York City in a big course and conference about the minimal invasive surgery and augmented reality. I was shocked. I knew these things exist. I've never seen them before. And during that meeting, I mean, there were like probably 5 or 6 different companies which introduced their augmented reality during the surgery, and it's mind-blowing. I mean, you can literally play with the spine on the air with your VR glasses, plan the surgery, plan how it works. So another publication from Spine Journal. This is a journal for North American Spine Society, which is again one of the the largest society of spine surgeons. Their publication about augmented reality, and this is from Johns Hopkins in Baltimore. So it's revolutionizing surgical education. It's revolutionizing the field, not only for spine surgery, but in general in surgery. So here how it works, and this is literally how it works. So VR glasses, augmented reality glasses, surgery patient, so surgeons see all this in front of him or her and perform surgery. So it has become a dominant player within the fundamentals of surgical education, minimally invasive spine. So again, this is the future, and the future is here now. What we have seen before now is becoming a reality and is greatly enhancing our. So why we are doing all this? To enhance patient care, right? To get greater results, quicker recovery with minimal damage. And all these tools are helping us. It's not just a beautiful tool, but it has its purpose, and it's serving its purpose greatly. Finally, I'm going to switch gears and talk a little bit about deformity correction. So this is like third part of the talk. And again, this is one of my area expertise, and I'm going to talk a little bit about that. And we'll start from kids. So we have seen like kids with bow legs or knocked knees, and we see these patients a lot in our community. Most of them they have this perspective or understanding that nothing can be done about that. That it's either major surgery or that they don't have that perception or understanding that it can be effectively corrected. So this is the normal development of the child. So at the age of 2, they are a little bit bow-legged, and then they are getting straighter, and then a little bit knocked knee, they finally becoming straight. So this is the normal development. So probably in your grandchildren, have you seen the kids with the bow legs? So my son was bow-legged when he was at this age, and guess what? I have hard time convincing all his grandmas that nothing has to be done, that he's gonna correct by himself, and of course no one trusted me on that, but eventually eventually he got straight. How about when there is a real disease and we need to do something? So we have things which we call guided growth, when we literally can guide the growth of the bones. So it's done it's very simple, like plate and screws. When we fuse the growth from one side of the bone and let the other side grow and compensate for this malalignment. And we use special tools to calculate all this. There is no eyeballing, there is no guesswork. It's all done using a special algorithm, special program. And this specific one was developed by my mentors, by people who I work with, had the privilege and honor to work with back in Baltimore. So it has proven to be great. What about if the patients are grown up? So grown-ups, we cannot do that, right? They are already grown up, there is no growth left, so we need to do something. I want to concentrate your attention on this X-ray. So this is the computerized reconstruction of problematic extremity. So the limb which was here knocked, the X-rays knocked, we use a special software, and on the computer we reconstruct it to help us to plan for surgery. Then we thought, how about if we try to reconstruct the patient body image as well, so they can see how they're gonna look after the reconstruction. And we ask ourselves a question, would it be okay, would it be desirable for the patients to see their reconstruction so they can be more confident on surgery, they can have realistic expectation, and they can have also know what to do during the surgery or what to expect after surgery. So it turned out that plastic surgeons, they are doing for a long time, and enhancing the shared decision and matching the available evidence with patient expectations. So we published this together with my mentors. We published this article, and we came to the conclusion that if you simulate the image of patient and give them to them and allow them to look at it and think about it, the results are much better psychologically for the patients. And they have less anxiety, they have better understanding, they have better expectations. So just like this young woman who came with this deformity, and with serial procedures we were able to correct her knock knee and get perfect alignment. Even you can see her pelvic tilt improved, her spine curve has improved, and all this with only correcting her legs and alignment. So here's another case when we not only corrected this deformity, but also lengthened the patient. So with these special tools, we have the possibility to lengthen the patient. You see the gap here between the bones? I know it's very subtle, but this gap is the area where the bone got lengthened. Not because we have to lengthen, but because this girl asked me to lengthen, and it was possible, and along with correcting this. So I think I added like approximately 2 inches of her height, so she became taller. It's not unknown technique. It's a very well known technique. So we can grow the bone using these special tools. So this has been around for probably 50 years, and it has been this is a patient from my prior practice. So these metal frames, they've been around for like 40 or 50 years, and we used to lengthen the bone using this one. However, again, technologies came to help us, and people who I had the privilege to work with developed this type of implant, which allows to lengthen the bone from inside, without all this torture device. Again, I had the honor to work with the people who developed and patented this device. So how it works? It's an implant inside the bone. So we do small surgery with teeny tiny incision, insert the implant inside the bone, and the patient lengthen the implant from outside. This is a special magnet which interacts with the gear inside the rod, which has also another magnet, and it rotates the gear, and it lengthens the bone. And you can see much less pain, happy patient, and happy overall outcome. Again, these are from my previous practice, and this is here at Monadnock. This young boy, he was scheduled to have his surgery at Mass General. Oh no, not Mass General. At Boston Children's Hospital. Yeah, thank you. And then eventually ended up having surgery here with us, and we lengthened almost 3 inches. And this is the final result. He is here local at Monadnock area. I was very happy. Yeah, and this was it. This was the last portion. I hope I'm on time. Yeah.
We have time for 1 or 2 questions, and we'll just ask you to try to repeat the question so it can get up. We're filming this, and it will be available on our website in a week or so. And so we just want to repeat the question. So
Sure.
When you showed a picture of the kyphoplasty that you had done, and you mentioned that you were going to have more innovative things than that, were you referring to more innovative than even a kyphoplasty?
No, I was. It's a different procedure. It involves radiofrequency ablation of the nerve, which is located inside of the vertebra. It is procedure is called Introcept. It was developed by a small startup in California, then was sold to Boston Scientific, and it involves radiofrequency ablation of the nerve inside the vertebral body. It's for low back pain. It's not for the fracture, so it's different things.
Not for stopping the pain of the fracture, the kyphoplasty still is the best.
Yes, for fractures, for osteoporotic fractures, kyphoplasty is the best. The one which I was talking about is in cases when, let's say, someone young and healthy has a chronic back pain on the background of certain wear and tear changes and nothing helps, then yes, we can we can do that procedure, and we are working with it's not yet here. Hopefully it will be soon.
Okay, thank you.
I hope this doesn't sound too basic. When you're doing the minimally invasive spinal surgery, how do you get those pieces that you put into the spine through such a small lumen in the tools?
Yeah, excellent question. So the question, excellent question. Thank you for it. So the question is, if we are doing minimally invasive, how we manage to put screws or rods through these small incisions? Obviously, if you put something big, incision cannot be smaller than something big, right? So usually the screws, the diameter of the screw, like biggest screw is let's say 6 millimeter or 7 millimeter, we do 7 millimeter incision. If the rod is 5 millimeter, we do a small 5 millimeter incision and we slide it under the skin. If we have to put a cage, again, we do small incision. The main thing is that we are not stripping the muscles off from the bone, which is the standard technique of when we do open surgery. Again, if let's say if I need to do 4 incisions for minimally invasive procedure, I do 4 incisions. If each of them is less than 1 inch, it's still better than 1 4-inch incision, because the incisions are different on the different spots. They do not involve muscle stripping. So it's still, again, I absolutely got your point that you are absolutely right. You cannot squeeze something bigger than the incision itself. But
Last question? Go ahead.
On the slide on knee and hips, I noticed something about radiation. Why would that be?
So yes, we were talking about we talked about radiation when we are using augmented reality and navigation. So with these tools, we can decrease the radiation, and this predominantly for the spine, not as much for the knees and hips, because knee and hip surgeries rarely involve X-ray and radiation, but with spine, it almost always involves radiation or X-rays. And of course, the primary beneficiaries here are surgeons and surgical staff, because we are exposed to that constantly every day. And patients as well, because if there are some patients who are having multiple surgeries, and lots of these procedures involve radiation. So it mostly refers, decreased rate of radiation, mostly refers to spine surgeries when we use augmented reality and navigation, and robotics as well.
David, did you want to close us out?
Sure.
I think yes. And please join us at the reception afterwards.
I was going to say.
Oh, sorry. Oops, I didn't steal your thunder.
Dr. Vache, thank you very much.
Absolutely, thank you.
And
My pleasure.
a small token of our appreciation.
Thank you.
We're a nonprofit, and we exist by the gifts that you all give us every now and then. I'd like to make a couple of announcements. If you're interested in next month's speaker, and
Ken Schilling of the Cornucopia Project.
Should
be great.
Please feel free to sign up while you're here. The Jaffe Village Improvement Society and the Jaffe Civic Center are hosting a Valentine's Trivia Night on Friday next week, if you're interested in coming. We will be having an interesting year this year. It's our 60th year been in existence, and we will be having some fun events throughout the rest of the year. Am I forgetting anything, Laura? Okay, well, please join us in the reception in the back, and we can talk a little more with Dr. Vache if you like more.
Thank you.